Well, good morning, everyone. Thank you very much for the opportunity to give you this talk. And I also want to start off by saying that it's a real pleasure to work with you all around the state and to receive referrals and to have some bilateral exchanges of ideas and how we can manage patients. So thank you for the referrals, and I really enjoyed the collaboration that we've had over the last few years. So before I begin, I want to share that the most common medication we use in pulmonary medicine is albuterol. And so albuterol is known as a short-acting beta agonist. So a Saba, short-acting beta agonist. And so people ask me all the time, hey, Dr. Saba, did you go into pulmonary medicine because of Saba? And I say, that's totally ridiculous. Of course that's why I went into pulmonary medicine. So I do participate in a clinical trial for patients with PCD, but the medications used in that trial will not be talked about in this talk. So there are many guidelines for pediatric asthma out there. There are American Thoracic Society guidelines. There are European guidelines. There are the NHLBI guidelines, which probably most of us have been using over the last few years for management of chronic asthma and acute asthma flare-ups in children. But these are getting a little bit old now. They were published in 2007, and these were American guidelines. So today I'm going to talk to you about a new set of guidelines from the Global Initiative for Asthma. And so the purpose of this talk is to give you updates on asthma. So this is the most up-to-date guideline, and this is going to be kind of the structure of most of the recommendations I'm going to share with you today. So these were published in 2018. Now, certainly you can use any guideline you want, and in fact, the NHLBI will probably be releasing new guidelines very shortly, but I'm going to share with you what the GINA organization is recommending. So some key features of asthma. Number one, it's an inflammatory condition. There's inflammation of the airways. Number two, symptoms are episodic, and the symptoms can be pretty much a number of different things. It could be cough. It could be exclusively cough. It can be wheezing. It can be shortness of breath, or any combination thereof. And a key component of asthma is that there's variable or reversible expiratory airflow limitation. In other words, there's obstruction to the airflow and it's reversible. There are some exceptions there in patients with long-standing asthma for many years who have had some remodeling of their airways. It might not demonstrate reversibility, but the strict diagnosis of asthma is episodic symptoms and reversible airways obstruction. So over the years, the prevalence of asthma has been going up, and I have a few theories that I'm going to share with you as to why that might be, but it's estimated that the prevalence of asthma today in the United States is approximately 10% of the population. So going back to Michigan Stadium here, 1,000 of those people are going to have congenital heart disease. 10,000 people in Michigan Stadium on a given day have asthma. It's a serious condition. 25 of those people have Kawasaki's disease. So there's a big discrepancy in who has asthma in a group of, in different demographics in a given population. Overall, children are more affected than adults, females more than males, Black non-Hispanics, Puerto Ricans, and those living below the poverty line. Pardon me, are at highest risk for having asthma. So what makes a patient develop asthma? There's a few risk factors. Number one is atopy. Any allergic or eczema type of history, any type of inflammatory condition that is an allergic type of inflammation will help drive asthma. So there's something called the hygiene hypothesis that states that in the past, when people lived more in rural communities on farms, the prevalence of asthma was much lower. And it could be because that environment skewed your immune system in favor of a Th1 phenotype, which is the allergic phenotype that mounts responses to bacteria and those types of things. Nowadays, kids are a little bit cleaner. They're not around germs and bacteria. So their immune system is skewed more in favor of a Th2 phenotype. And that's the phenotype that elaborates inflammatory cytokines of the allergic immune system. IL-4, IL-13, mast cells, basophils, eosinophils, and those are the inflammatory components that drive asthma. So some people hypothesize that the prevalence of asthma is going up because our kids are just too clean. So genetics obviously play a major role. If there's a family history of asthma, a child is at risk for having asthma. The environment plays a major role. And another environmental factor that I consider would be prematurity, chronic lung disease from prematurity. Even if the child is a late preterm baby, that puts you at risk for having asthma. Viral infections, we know for certain that early life exposure to RSV and rhinovirus in the first 6 months of life are a major risk factor for the eventual pathogenesis of asthma. The human microbiome is probably a contributing factor. We don't know too much about exactly how that contributes, but the human microbiome, meaning all the bacteria we normally have, not just bad bacteria, the bacteria we normally have, and the contribution of one group of bacteria to another bacteria, that's the microbiome, that contributes to the pathogenesis of asthma somehow. So what's the inflammation in asthma? Well, there are many different types of inflammation you can have in asthma. There's neutrophilic asthma, there's eosinophilic asthma. Today I'm gonna focus on allergic asthma. It's probably the most common type you're gonna see. So in allergic asthma, you've got most of the problems start at the airway epithelium here. Your airway epithelium elaborates some cytokines, IL-25, IL-33, which then leads to the further proliferation of key cytokines here, IL-13 and IL-5, and these go back to the airway epithelium, and the airway epithelium then elaborates chemokines, which attract cells. And which cells are attracted? Your big-time allergic cells, CD4 plus Th2 cells, basophils, mast cells, eosinophils, and these are the cells that produce histamine, leukotrienes, prostaglandins. Those are the things that cause your bronchoconstriction and goblet cell hyperplasia and mucus accumulation and those types of things. So this is the basic concept of allergic inflammation of the airways causing asthma. Now what happens to the airways over time? So on the left here is a normal airway, a nice open lumen, there's not really any fibrosis, a normal amount of smooth muscle. In a patient with asthma, the lumen is much smaller. And that's because there's massive proliferation of goblet cells around the epithelium. There's lots of smooth muscle here. This is airway remodeling, okay? And you also have a significant amount of collagen and fibrosis. So there's airway fibrosis, there's smooth muscle hypertrophy and proliferation, and there's goblet cell hyperplasia. This is airway remodeling. Now this is reversible, except in a patient who's been living with this inflammation for a really long time, at which point this might become irreversible. How does one make the diagnosis of asthma? Well, as I said before, there are key clinical features. There should be episodic symptoms of shortness of breath, chest tightness, wheezing, coughing. In addition to that, there should be evidence of reversible airways obstruction. So one way to test for that is to simply get that on history. Does your child respond to albuterol? Does the wheezing go away with albuterol? In a patient who's old enough to perform pulmonary function tests, that's a really key part of your diagnostic workup. Here we have a flow volume loop. As a result of spirometry. This is a normal flow volume loop. This is a flow volume loop of a patient who has airways obstruction. This characteristic scooping of the expiratory portion of the loop suggests that there's obstruction of the airflow. This is a volume time curve, so the patient blows into the spirometer, and the amount of volume they can blow out is called the vital capacity here. Now the volume blown out is in 1 second is called the FEV1. And so if the volume blown out is 1 second, in 1 second is much less than the total amount of volume they can blow out, it means that there's some obstruction to that airflow. So the FEV1 to FVC ratio is an important predictor of airways obstruction. Now, if you give your patient albuterol in the clinic, 4 puffs of albuterol or so, and there's a 12% improvement in FEV1, that's diagnostic of airways obstruction with reversibility. Now you can determine the severity of the obstruction based on the FEV1. This is not the severity of asthma. The severity of asthma is based on different criteria. This is the severity of the obstruction that contributes to your determination of asthma severity, but this is simply severity of the obstruction. So you make a diagnosis of asthma in your patient. Then you try to determine how severe is this asthma, and then what am I going to do about it? So to make a determination of asthma severity, it's based on the amount of asthma medications needed to control the asthma. So it's actually a diagnosis provided retrospectively. If you determine in clinic a few months later that on this level of asthma control on this level of asthma therapy I've achieved control, then it's this degree of severity. For example, if your patient's controlled on step 1 or step 2 of therapy, and I'll show you what those steps are in a minute, you say it's mild. If they're controlled on step 3, it's moderate. If they're controlled on steps 4 or 5 or not controlled at all on steps 4 or steps 5, you call it severe. So I'm going to talk mostly about children older than the age of 5. In kids less than 5, the management is a little bit different, and I'll tell you why that is. But in children older than the age of 5 and adolescents and adults, you initiate inhaled corticosteroids if your patient has asthma symptoms more than twice a week. I'm sorry, month is incorrect. It's more than twice per week, okay? If they're waking due to asthma more than twice a month, so that should be month, and if they're having any asthma symptoms plus any risk factors for exacerbations. And I'll show you what those are in a minute. So if you have any of those things, you should start your patient on an inhaled corticosteroid. Many people request referrals to pediatric pulmonary at this step, and that's entirely appropriate. And I'm thrilled to get involved at this step of therapy. The GINA guidelines suggest referrals at a little bit of a later step in management, but you refer whenever you want to, and I'm more than happy to see patients at this step to help determine what controller to start them on. And you can consider starting at a higher step, like step 3 or 4 of therapy, if the patient's got troublesome asthma symptoms on most days, or if they're waking from asthma more than once a week, especially if there's risk factors for bad exacerbations. So this is what the GINA guidelines have for asthma management at this point. This is a busy slide, but I'm going to walk through it. So obviously the steps mean if the patient is not well controlled, you step up. If the patient is well controlled, you can step down. So step 1 is where you might just start some short-acting beta agonists and see how things go. Step 2 is when you start your inhaled steroids. And there are some additional medications they're recommending, like leukotriene receptor antagonists. Theophylline is not one that it really has any level of popularity after the 1980s, really. So I wouldn't use theophylline, and most pulmonary specialists do not use theophylline. But it's on this grid here. So step 3 is when you start using your inhaled steroids with long-acting beta agonists. In kids less than 12, they're saying, well, hold off a little bit on the long-acting beta agonists and just use medium-dose inhaled corticosteroids. And so you go up and up from that point. So let's say, so another thing I want to point out on this table is reliever medications are medications patients should take whenever they feel symptomatic. So short-acting beta agonists are the mainstay of reliever medications here. They are suggesting the use of inhaled steroids with long-acting beta agonists, for example, Symbicort, as reliever medications. Now, in our practice, we have not adopted this practice yet. There is some data to show that in adults, it might be beneficial to do so, but those data have not held up in kids. So I still recommend using albuterol exclusively or an anticholinergic in some cases as your rescue medications and not using your long-acting beta agonists with inhaled corticosteroids as reliever medications. If you care for adults as well, then you might also consider that. But in kids, that has not really been part of our practice in our division. So you start your patient on asthma therapy. Then you see them back in clinic a few months later. You assess, you review the response. You assess their symptoms. You assess their exacerbation risk. You assess for side effects. You determine if the patient is satisfied, and you determine lung function. Based on this, you make an assessment of whether or not their asthma is controlled. And if their asthma is not well controlled, then you make an assessment for why that might be. You confirm that you're dealing with the right diagnosis first. You talk about symptom control and risk factors. Maybe there's a major comorbid condition I'm missing here. You assess inhaler technique and adherence. And you talk about patient preference. Then you adjust treatment. That might be adjusting asthma medications, but most of the time, it's going to be non-pharmacological strategies, which I'll tell you about in a minute. And you treat your modifiable risk factors. So this is the overall approach to outpatient asthma management from the GINA guidelines in kids older than the age of 5. So you start an inhaled corticosteroid. Problem is, which one do you use? There are many inhaled corticosteroids that are delivered in many different delivery devices. And I'll be quite honest, I know about all these, but I've probably only used about half of them. I have mine that work really well for me and I'm really used to, and I know really well how to educate families on them. So you kind of want to probably pick 2 or 3. You certainly don't have to be an expert in all of these. There are some that come in the form of a powered meter dose inhaler. There are some, and most of these are patient actuated, okay? The only ones that are not patient actuated, that just kind of blow into the patient's mouth, are the meter dose inhalers, the Respimat, and the nebulization. All the rest of these require a significant amount of inhalation on the part of the patient. Some of them are dry powder inhalers, some of them are HFA devices. So like I said, you don't have to know about all of them because there are many of them on the market. Maybe I'd recommend getting comfortable with 2 or 3. I have this in my office because oftentimes patients get referred to me and tell me that they're on a medication but don't know the name of it, and I don't get a whole lot of notes. So it's nice that these all come in different colors so they can point out on your poster what they're on. So the basic concepts of inhaled corticosteroid therapy is you should treat with a minimum effective dose that treats symptoms. As soon as my patient's well controlled, I start stepping down inhaled steroid therapy. In kids less than 5, I would recommend using a meter dose inhaler or a nebulizer. I wouldn't recommend the dry powder inhalers or the patient-actuated devices in kids less than 5 because I don't think they're generating enough inspiratory force to get it down to the lower airways, which is really where you want for it to go. Meter dose inhalers should always be used with a valved holding chamber. And as I said before, breath-actuated devices like the RespiClick, ReadyHaler, HandyHalers, these should always be used in kids just older than the age of 6 who can do it appropriately. So when you see your patient, a few more details about how to assess asthma control. So what are the questions you want to ask them? These again are the GINA guidelines. The questions are a little bit different in the NHLBI guidelines. So if they say yes to 3 out of these 4, are you having daytime symptoms more than twice a week? Are you having nighttime symptoms more than twice a month? Are you needing your reliever medications more than twice a week? And do you have any exercise limitations? If they say yes to 3 out of these 4 questions, your asthma is poorly controlled. You want to assess for risks as well. So you want to get lung function if you have that capability in your office. And that would be FEV1. I'm not talking about peak flow meters. I'm talking about FEV1, which has to be done with a spirometry machine. Most people don't have those capabilities. So you want to assess risks in other ways. Exacerbation risk. What's the risk this patient's going to have a bad exacerbation in the next 6 months? Basically, if they have uncontrolled symptoms, if they're using a lot of albuterol, if they're having more than 1 exacerbation a year, if they're not adherent, if they're smoking around in the home, if they have lots of comorbidities, if they have elevated FeNO, which is a measure of lower airway nitric oxide, which is a marker of eosinophilic inflammation. We do that in our pulmonary clinic, and if they've ever been intubated for asthma. These are risk factors for bad asthma outcomes, and that's certainly something you should assess periodically. So what are the non-pharmacological interventions? And I would say these occupy most of my time when I visit with patients. Choosing an inhaled steroid is actually pretty easy. Adjusting doses, I mean, there's a protocol for that. I don't really need to be involved for adjusting medication doses. This is probably the main area where we can be mostly helpful. So every patient needs an asthma action plan to tell them what medications to use when they're feeling well, what medications to use when they're not feeling well, and when to call the office. Every patient should have lots of education at every single clinic visit. We have a designated nurse educator that does this with all of our patients who have asthma. Talk about adherence and technique. It's estimated that 50% of patients, both in kids and adults, and this is well supported in the literature, are not adherent to their medications the way it's prescribed. Now, what percentage of patients have inadequate technique? In my experience, I would say close to 80% of patients have poor technique until I see them at least 3 times in clinic. Environmental exposures are also a major risk factor. If I have a patient with human dust mite allergies and they're not appropriately avoiding those dust mites, their asthma is not going to be well controlled. Addressing comorbidities as well, obesity, acid reflux, rhinosinusitis, obstructive sleep apnea. and immunotherapy, which is considered a non-pharmacological approach. So just a few words about asthma in preschool children. So why are we talking about this as a separate group? So this study was done, probably many of you are familiar with it. It's a famous study done in Arizona about 30 years ago, and they looked at all kids entering school. And they said, how many of these kids have ever wheezed? And among all their 6-year-olds, about 50% of them had a history of wheezing. And among those that wheezed, a third of those kids wheezed early in life and then grew out of it. They called them transient wheezers. Most of those kids had maternal smoke exposure. A third of them only started wheezing later in life, like after the age of 3. And a third of them started wheezing early and continued to wheeze at the age of 6. They called those persistent wheezers, which many of us would call asthmatics. Those who have asthma really had a strong atopic family history or personal history. So the reason this study is important is to say that most little kids who wheeze don't have asthma, and they'll probably grow out of it. And it's really hard to determine if, a 2-year-old coming to clinic with wheezing truly has asthma, or whether they just have viral transient wheezing that they'll grow out of. Once the patient ends up in my clinic, usually you have all done a really good job making that assessment. And my job is easy at that point, but I do want to give you a few extra tools to help make that distinction of determining whether a young child truly has asthma or whether it's just viral wheezing that they'll grow out of. So kids with just viral wheezing usually have illnesses that last for a shorter period of time, less than 10 days. They have few episodes 2 to 3 times a year, which actually I would say that's very conservative. I'd give them at least 5 or 6 episodes of wheezing per year before I get concerned, and no symptoms between episodes. Those who you'd worry more that they probably have asthma are those who have illnesses lasting more than 10 days, more than 3 episodes a year, and again, I'd say probably more like 5 episodes a year would be appropriate. And they have symptoms between illnesses of coughing and wheezing and those types of things. And lastly, a strong personal or family history of atopic disease. Those are the kids that I would say, well, you know what? You're wheezing with colds, but you might very well be wheezing because you have asthma, and I'm more likely to treat you as though you have asthma here. I think all of these kids probably need a short-acting beta agonist at home, because the response to that short-acting beta agonist is another really good predictive factor of whether or not this is truly asthma. And it's just another piece of history that's going to help you determine whether or not this child needs to be on an inhaled corticosteroid or not. So why do we have to go through this process? Why not just say, well, it's asthma, you might grow out of it, I don't really care if it's asthma or not, we're going to treat it the same. Well, there are many other things it could be. And so it's important to go through a thorough evaluation. And if you have any concerns that you're dealing with any of these conditions, we're more than happy to see them in clinic to provide further consultation and workup if needed. With bronchoscopy and sweat test and CAT scans and whatever needs to be done to look through all these potential things that might be playing a role in why this young child might be wheezing if it's not asthma. So the GINA guidelines have a different table for how to manage children less than the age of 5 once the diagnosis of asthma has been established. And that is, as I said before, frequent illnesses lasting for a long period of time. Once you've made that diagnosis of asthma, you start them on a daily low-dose inhaled corticosteroid. Now, there are tables through the GINA guidelines to tell you what low-dose, medium-dose, and high-dose inhaled corticosteroids actually are. For example, fluticasone dosing is going to be different than beclomethasone dosing, even if they're still low dose. And I would recommend that you go, I have them in here, but it's just numbers, and you can certainly go look at those tables if you're interested in knowing what low, medium, high dose truly are. So they are saying, obviously it's the same approach. You step up if they're not controlled, you step down when they're not well controlled. And they are saying to refer when you get to step 4. But I'm saying, and usually what we do once you get to this point is we would consider starting on a long-acting beta agonist, getting further diagnostic tests and those types of things. But I don't think you have to wait till step 4. We're more than happy to see patients even at step 2 if you have a question of whether this is asthma or whether there's something different going on that I should work up before starting this patient on long-term asthma therapy. So you can refer at any step. So a few words about allergy immunotherapy. If you've really confirmed that your patient has atopic asthma, and they are around perennial allergens. Sometimes you just can't do anything. You can't avoid perennial allergens 100%. Immunotherapy might be a good option. This is not something we provide in pulmonary clinic. It would be in allergy clinic, but I want to share with you how it actually works. So when somebody is exposed to a low-dose allergen every day, their immune system is ramping up the Th2 limb. In other words, the limb of the immune system that elaborates histamine, leukotrienes, and prostaglandins, and the mediators that drive the constriction of the airways. When you're giving the patient a high dose of allergens through immunotherapy, the immune system behaves much differently. It goes towards the Th1 branch of the immune system, and you elaborate totally different cytokines like IL-10, which suppresses the Th2 limb, and you produce plasma cells which elaborate IgG4, which also suppresses the Th2 limb of the immune system. So allergy shots actually make the immune system work differently to block the allergic component of the immune system and drive down that atopic inflammation that's contributing to the asthma. Okay, so the GINA guidelines are saying that they recommend it for adults with dust mite sensitive patients who have bad asthma. I would say this also should definitely be a part of management for children with atopic asthma. So these are a couple new things on the market here. Omalizumab is a monoclonal antibody against IgE, and as you know, IgE binds to mast cells and it degranulates and releases histamine and things like that. Well, if you can kind of get rid of some of that IgE a little bit and bind it up with this medication, then there will be less IgE binding to your mast cells and less degranulation of those mast cells. So this is a medication for kids. It's FDA approved for children older than the age of 6. In those who have poorly controlled moderate to severe allergic asthma with high levels of serum IgE, and you have to document that they also have cutaneous allergic reactions. And it's been shown in this Cochrane review that it limits the amount of exacerbations and hospitalizations, so it definitely works, but it only works for the right type of patient. There are other medications like mepolizumab and reslizumab. Mepolizumab is for those older than the age of 12. Reslizumab is for those over 18. And these are monthly subcutaneous injections for people who have allergic asthma, but their allergic asthma is driven mostly by eosinophils. So you need to also have poorly controlled atopic asthma and 2 or more exacerbations per year with eosinophils over 300, or 3 exacerbations per year with eosinophils over 150. So if you have a patient with bad asthma and you know that they also have eosinophils in their blood, lots of eosinophils in their blood, this might be the right medication for them. It's a little bit newer on the market, so it hasn't necessarily had we haven't had as much experience with it as we have had with Xolair, but it certainly has been proven to improve the quality of life and reduce exacerbation rates. So in asthma flare-up, just a couple key concepts here. The GINA guidelines are suggesting the use of the term flare-up instead of attack or exacerbation. Oral steroids are going to be key. Recommended that you taper those steroids down if the patient's been on it for at least 2 weeks, and close follow-up. Now, there is some data that came out this year in the New England Journal with a few studies that looked at whether you should increase the dose of the inhaled steroid during an exacerbation. And these data are from an adult study which showed that in adults that quadrupled their dose of inhaled corticosteroids during exacerbations, there were fewer bad exacerbations. In other words, they were able to get over those exacerbations without needing oral steroids. So this is the group that quadrupled their inhaled steroid. This is the group that did not quadruple their inhaled steroid. And the bad exacerbation rate was better in those that did quadruple their inhaled steroid rate. Similar study was done in kids, and it did not hold up. The rate of, so kids that quintupled their inhaled steroid rate during exacerbations still needed those oral steroids. So in the end, you just had kids on oral steroids and quintupled doses of inhaled steroids, and they ended up with growth problems. So just increasing the dose of inhaled steroids during exacerbations doesn't really work very well in kids. It's gonna be oral steroids in kids. In adults, it might work. So growth concerns are a real is reality in kids that are on inhaled corticosteroids. This study came out in the New England Journal in 2012 that showed that in kids on relatively high doses of budesonide, they had a decrease in their mean adult height by about 1.2 centimeters. It happened early, like in the first few years, then it didn't get any worse after that. So it happened early and remained stable. This was a meta-analysis in 2015 that kind of showed the same data, that the kids on long-term inhaled steroids might be about a centimeter shorter than they otherwise could be, potentially. Certainly doesn't happen in every patient, but that's a serious risk. Now, what do I tell families? Your child has a very serious chronic condition that has a high rate of morbidity and mortality. And if they're a centimeter shorter than they otherwise could be, that might just be a risk you're going to have to accept in order to get their asthma under good control. And I've almost never had a family refuse because of that reason. I have families who want the data, so I give it to them. But it's a bad disease. You need to treat it. So a couple words about peak flow meters. I really don't use them in my practice. There's a lot of variability. It depends on the patient effort. The numbers depend on the device that you're using, like the reference ranges depend on the device you're using. It might be valuable for teenage patients that have been living with it for a long time and don't recognize their symptoms so well. So it might be good for poor perceivers of symptoms, and poor perception of symptoms is a major risk factor for mortality. So in those that perceive their symptoms poorly, it might be good. Might be a good way to just kind of trend over time how things are going, but self-monitoring is the most valuable way to determine whether a patient needs to be treated for an asthma flare-up. So thank you for your time. I welcome any questions, and I welcome your referrals, and I'm happy to even talk about patients on email. It's a pleasure for me. Thank you for your time.